Without further ado, I'd like to move on to our first speaker. I am absolutely delighted to be able to welcome Bruce Marshall to New Zealand. Bruce has been here a couple of times and spoken to and met with our respiratory doctors at their respiratory meeting that is sponsored by Boehringer Ingelheim in July of every year in Rotorua. Bruce has been a particular help to me as we have got the our data registry, Port CF NZ, up and running in New Zealand. In fact, he has absolutely been my go-to guy, even when I've asked him really, really dumb questions, so thank you for that. Bruce earned his BA at Johns Hopkins University, his medical degree at the University of Maryland School of Medicine. He did internal medicine house staff training at Strong Memorial Hospital, University of Rochester, and a pulmonary fellowship at the Boston University School of Medicine. He was an associate professor of medicine at the University of Utah Health Sciences Center and the adult CF program director at that institution from 1988 to 2002. His research interests centred around CF-related epidemiologic and clinical research, and Dr. Marshall joined the Cystic Fibrosis Foundation at their national office in Bethesda in the US in 2002. He's the Vice President of Clinical Affairs, and he oversees the Care Centre Network, clinical practice guidelines, patient and family resources, as well as the work of the clinical research, patient registry and centre committees. His primary responsibility at the Foundation is to lead their quality improvement initiative, and quality improvement is why we are all here this weekend. Dr. Marshall also holds the appointment of Associate Professor of Medicine at the Johns Hopkins University School of Medicine, Baltimore, Maryland. Welcome, Bruce.
Good morning. I didn't expect how many people would get up this early on Saturday morning, so it's a treat to see all of you here, and it's a pleasure and an honor to be here. When I heard the title for the conference this year, Getting Better Together, there was no way I could say no to the invitation, because that's the reason I joined the CF Foundation, and that's what we do. We work for people with CF and families with CF. So I was delighted to hear about the title of the conference, and I'm really delighted to spend some time with you. And I don't particularly like this setup because I feel like I'm up here too high. I'd rather be down with you. I hope I can get you speaking some this morning so I don't have to work too hard. I'm very eager to hear your thoughts about my topic this morning. So the title is what people with CF and their families can do to improve care. And before I get into that topic too deeply, I want to review some background just to provide a little context. And then I'll get into the topic of improving care. First of all, in all of the countries around the world, the number of adults are growing. And I think that's the case in Australia, it's the case in New Zealand, and it's certainly the case in the US. And I'll show you just a graph from our patient registry. And you can see that green line are the number of children, and this graph goes from 1986 up through 2011. And you can see in that last decade it sort of plateaus out. But look at what's happened to the number of adults, that blue line. If you go back to 86, about 2/3 of people with CF were children, 1/3 adults. Now it's rapidly approaching 50-50, and we project that trend into the future. So we assume in 20 years there'll be 2/3 adults. By that I mean 18 years and older. So that's one of the key trends I think we have to be aware of. You're probably aware of the more stringent infection control policies that are coming into place, and perhaps that's caused some heartburn for some of you, as it has done for some people in the U.S. And I won't focus on that, but would be happy to discuss if there are questions about that later. The high cost of care. This is a worldwide issue as chronic diseases become more prevalent and particularly in the developed world, more chronic diseases and multiple chronic diseases. So there's increased pressure to sort of justify in CF our care model and the prescribed therapies, which, as you know, are very expensive. And then the increasing treatment burden, as we've seen more and more therapies approved and available to people with CF and families, the treatment burden has really gone up. And this is a picture of a young woman about 18 years of age, about to go off to college, and pictured here are all of her treatments that she takes throughout the day. And if you do a rough calculation, most of the care for CF doesn't happen at the clinic or the center or in the hospital, and you know this, but sometimes you have to remind the clinicians the care happens at home. So a rough calculation, about 97% of the care for CF actually happens outside of the clinical setting. It happens at home. And this treatment burden has been quantitated by an investigator in the U.S., Greg Sawicki and Walter Robinson and colleagues, and they followed at about 10 care centers in the U.S. how much time people with CF, young adults with CF, spent. And in that red bar, it shows the average, almost 2 hours per day, and then the breakdown for inhaled nebulized therapies, treatments by mouth, oral therapies, airway clearance, and exercise. So an enormous treatment burden, as well as a symptom burden in people with CF. So let's get into the topic at hand, and here's where I'm hoping, get your shoulders and arms loosed. I want to hopefully see some people raise their hand. I want to get into the topic of what you can do as individuals with CF or parents of children with CF or grandparents, brothers, sisters, what you can do for your own care or your child's care, what you can do in collaboration with your care center, and then what you can do at sort of the higher level at your country. So some of this, I come from a clinical background. As you heard from Kate, I'm a physician, and to be honest with you, patient engagement really wasn't on my radar screen. I was really sort of trapped in that medical model. But I've become very much a fan of patient engagement and partnership, and particularly for chronic diseases where the treatment burden is as I've described. I think this is sort of the secret. I think this is where we're going to get the outcomes that we want to get. So some of this thinking comes from quite a bit of reading I've done on this topic, but one in particular I'll point out to you is this book that's a very easy read. I read it on a flight. It was a 2-hour flight. I got through the whole book. It's entitled Let Patients Help, a patient engagement handbook. And it's written by this Dave DeBronkart, also known as ePatient Dave. You can find ePatient Dave if you just Google ePatient Dave. And his story is he had some pain in his shoulder. He went to see the doctor. They did an X-ray, and they found a lesion, a mass in his chest. And then they did a CT scan, and they found that he had kidney cancer, and it had spread through his body. He was given a poor prognosis. And the doctors really didn't offer him much hope. And he joined a patient website called ACOR, and I forget exactly what that acronym stands for, but it's targeted towards patients with cancer. And he went on that site and he identified himself and his circumstances and asked people what they did, if any of them were in a similar circumstance. And he relates the story that within a few hours, he got 3 or 4 posts back that described a therapy that was available, that it helped them, and where he could access that therapy. And it's a very toxic therapy. It's called interleukin-2 therapy. And because of the toxicity, a lot of physicians don't offer it. Well, he pursued that therapy, and in fact, it, for him, proved to be curative. And he's now out several years from this therapy. And from that experience, he's gone on to sort of be a sort of an advocate for patient engagement and trying to develop this partnership with clinicians. So I'd encourage you to look him up. So this is the first suggestion, and in some ways I know I'm preaching to the choir here. If you've shown up, I think you are an e-patient. And what I mean by, and you could generate a list as long as this slide with electronic obviously is one of them, but engaged, educated, empowered, enabled. You could think of some other E words, but you catch the drift of where I'm going there, is to really sort of take charge of your own care. So I'll spend a little time.
Any questions?
What kind of service plan does this come with?
Unlimited.
Can I keep my same phone number?
Absolutely.
How do I change the ringtone?
Just hook it up to your computer.
Does it have a camera? What's the warranty? Does it come in silver? Can I put my party shuffle on this? Does it have a 3.5 millimeter headset jack? You sell a lot of these?
It's the one I carry.
You ever get those phantom vibrations in your pocket?
Any questions?
No.
Are you sure?
Yeah.
Ask questions. For the 10 questions everyone should know, go to ahrq.gov.
What do you think? What do you think of that video? Sorry, I didn't set it up right, but I thought that was really entertaining, and it sort of gets to the point of you've got to be engaged. This guy was so engaged on his cell phone, and the various attributes that were available to him. Does that bring anything to your mind as you think about your experience in healthcare? I saw somebody shake their head. You want to be brave and start and comment your... He backed off. He took a step back. Anybody brave and want to say, reflect on your own healthcare experience. Now you're veterans. You've been there. You know your clinicians. You know the nurse. You know how to get the information you need. But reflect back on your experience early on. Thank you. Maybe everybody didn't hear that, but it's a great comment that early on she related that she felt intimidated. All the medical people in the room with presumably all the knowledge that knew all the answers, and she wasn't sure of herself. But over time, she's gained that confidence.
Bruce, just wait for the mic.
Oh, okay, we have a
So
mic.
they can pick it up on the phone. Who was that? Had their hand up?
Good morning. I'm a CF mother as well. My daughter's 11, and I'm going through the process at the moment of trying to get her to engage and ask questions, because quite often we gain our confidence as parents, but I think we're also teaching our children that we'll ask the questions, and we'll sort of be engaging with the physicians, and they tend to sit there because most of it they don't want to know, in my experience. So that's my challenge at the moment, to get my daughter to be asking questions, and because she'll go home and she'll ask me the questions. And okay, and in most cases I know the answers because they're questions I've asked. But yeah, I think that's the biggest challenge, because I want her to be able to communicate with the doctors as well and have confidence that she's got her rights and assert those.
Great comment. And anybody in a similar situation or experienced that same situation where you have a teenager and you realize that he or she is going to be an adult, and probably already as a teenager she started to create some separation and some distance, and you recognize you're going to have to start to shift the burden over to him or her. And then there's that fine dance that you want to be there. You've been there all along, and you'll always be there. But it's time for him or her to start to assume the responsibility. It's a really difficult time and a challenging time, and some people drop off in their health at that point because that transition doesn't go as well as it might. But thank you. There was another comment.
Yeah. I always find that if I don't go without a list, I kind of, forget everything once I'm in the doctor's. So it's all, like the the 8 weeks before clinic, when things pop up, I try to write them down. Otherwise, you do feel a bit intimidated, and you don't remember once you're in the office with the doctor. Yeah.
It's great point. I hope everybody heard that. Come with your list. These are the questions you're going to get answered before you leave. Of course, they have a million questions, and they have their own agenda, but you need to bring your agenda as well, and be prepared that at the right time you're going to slip those questions in, and you want those things addressed. Any other comments?
No, you need to be picked up by the phone.
This isn't a comment, it's a question, but I'm just wondering how you feel when you're challenged as a clinician, if the patient is actually challenging something, and let's assume it's something that's worthwhile and not something trivial. Just wondering how that feels.
It's a great question. I think everybody heard that. How do you feel when, as a physician? How do you feel when you're challenged? If you get defensive about that, or if your clinician gets defensive about that, that for me raises a red flag. I mean, we're here to serve people with the disease. I think that we have to recognize that. Back to that point, more than 97% of the care happens at home. So in many ways, we're in an advisory counselor sort of a role. And I think, this is my opinion, I think clinicians should feel like they want their patients to come in and not so much challenge, but bring up ideas and just say, oh, I've talked to so-and-so that said this, or I've seen on the internet this. What do you think? You would want your clinician's opinion, right? Because they have the broader medical knowledge and the context and the practical experience of caring for tens, hundreds, maybe thousands of other CF patients. You want their help in terms of putting it into context and their practical wisdom. So we've seen this. We've seen this. Clinicians that, oh, you're asking me. That to me raises a flag, raises a red flag. I worry about that. And we certainly try to encourage our clinicians to be open-minded. It's a good question, and I think it gets at, in some ways, how diplomatic you have to be in terms of getting your point across, and be careful not to offend, because ultimately you do need that partnership, right? You can't prescribe the medications; only they have the authority to do so. So I think it's a little dance that you have to do. Push, and then when you get the resistance, back off a little bit. And then one of the nice things in CF is it's multidisciplinary care. Sometimes you can get at it. It's typically the physician sometimes is a little, but maybe you can approach it through the nurse or the social worker or another team member to sort of get the information you need. Does anybody understand what I mean? That there's a little bit of There's a little bit of an intimidation factor there, that if that clinician doesn't have the right mentality, there could be a little danger there.
Hi, can you hear me all right? Oh, I don't like speaking with these. Hi, my name's Louise. I'm a home care worker for CFWA, and just on that point you commented on then, a lot of my families are not totally open and honest with what they share at the hospital and with the doctors, because it's, from my opinion, it's very, from the doctor's point of view, it's very black and white, which is, I found the 90% of care happens at the home very interesting. So from my point of view as a home care worker, I can get the information from the families that sometimes they don't want to share, or not necessarily that they don't want to share, because if it's private, but that they're too scared to share because sometimes the doctors take it as black and white and not as a, this is how life is outside of the hospital. So, yeah,
It's a great,
good.
That's a great point. I hope everybody heard that. I think you're absolutely right. The information doesn't always flow through the physician.
No.
It can come from multiple sources. And I think a wise clinician recognizes that and is able to get the information that perhaps a family would volunteer, say, for example, to a respiratory therapist that they've developed a good relationship with, maybe on a previous hospitalization, and then be able to pull in, if there are team meetings, to pull in all of that key information when they make decisions. So I think that's a great point. You're an easy crowd. Sometimes it's hard to get people talking. Thank you for those comments. Appreciate that. So let me move on. There's some other points where I want to get your input. So listen closely. So this is about how much knowledge is out there now. I mean, there's just been an explosion of medical knowledge, and even in a very, what you might consider a narrow field like cystic fibrosis, it's virtually impossible to be up to the minute, up to date. So this comment, and this came directly from ePatient Dave's book. I like it. It says, we all know something, but no one knows everything, not even doctors. There's a real cutting edge to his book about physicians in there that I was offended at times, but when you get beyond that, it's really kind of funny. So this is the other E, and again, I'm preaching to the choir. You're here. Educate yourself about CF. Arm yourself with knowledge. Your clinician, for whatever reason, may not be up to date in a particular area. You always want to be that safety net as best you can be. So learn all that you can. And I'll just list a few bullet points here. Ask your care center or clinic what resources they have available or where they would point you for educational resources. Think ahead. Think about if you have an infant, what's the next milestone that you're going to need some information. And maybe it's not medical information. Maybe it relates to taking your child to school and who could be helpful there. Maybe it's the social worker or the psychologist or the nurse. And then get the materials you need there. Seek out others for their insights and their experiences on various aspects of what you're dealing with. And as Kate pointed out, I think that is the power of a venue like this. You can learn from one another, sort of the practical wisdom and learnings that you've gained over the years. This, from a clinician, some clinicians think this is dangerous. Don't go on the internet. You'll see misinformation there. There is some misinformation there, but if you look and you go to reputable sources and if you go back to your care team and say, look what I've found, then they can tell you, oh, don't believe that. That's not real, and tell you why. 9 times out of 10, you're going to find good information. And I'll give you an example. There was a therapy it was actually a parent that wrote about this therapy, and she came from a very strong scientific background. It was inhaled glutathione. She became absolutely convinced that was the cure for CF, and she was promulgating that word through the community, and they were going to their clinicians, and she was sort of trying to create a revolution. Oh, the CF Foundation and the clinicians are ignoring this piece of data. Well, we weren't really. I mean, we were trying to organize the right clinical trials to test it. So, we just encourage patients and families, go back to your care teams and talk about it and hear the full story and hear the clinical trials that are being developed and how we're going to test that. And in fact, there was a trial in Germany that was conducted to test this therapy, and it showed that it wasn't beneficial. She was on the right track, but her, in terms of an antioxidant, but that approach that she was taking had some flaws, and now it's being approached in other ways. This is another comment that may be sacrilege coming from a clinician. How many people here are on some sort of a social networking site that you use for healthcare related issues? Okay, Which sites do you use? Facebook, I heard. Any? Where? Twitter. Any of these other, like I mentioned for cancer, the one that e-patient Dave joined called ACOR. Anybody that's on a site like that, there's one that's getting a lot of new. New Zealand Health Forum. There's one in the U.S. called Patients Like Me. I don't know if anybody's heard of that. It's focused more on neurologic diseases, but there is a community with CF that's on that site as well. And that site, just like ACOR, it's, and I guess Facebook, I don't know, I'm from a different era, I'm not on the, but you can sort of control your privacy settings. I guess you can do the same on Facebook. It's the same like in these sites like ACOR or Patients Like Me. So you can just share within that closed network if you like. I think there's a lot of practical knowledge and wisdom and sophisticated knowledge on these sites. So sometimes I think this can be a benefit you can learn here. So, okay, so that's about engagement and education. So if you're engaged and educated, that sort of allows you to do the next things and to be empowered and enabled, to stick with that E theme. So an empowered person knows what he or she wants and speaks up. Not like that little video. He was intimidated, he didn't speak. And then when faced with a challenge, an empowered person would say, well, you know, what can I do? Whereas a disempowered person says, no, it's hopeless. Nothing I can do. And again, I know none of you are in that situation, or you wouldn't be here. So how does this apply to CF care? Well, it's back to that early slide about 97% or over 97% of the care happens at home. Recognize that the locus of control it's in your hands. You're sort of determining what happens day in and day out. And that's an important recognition, and it gets you thinking a little bit differently about your clinical team. And we try to convince them their role is to be sort of the experienced, trusted counselors to provide the right advice. But the locus of control is with the individual with CF or their families. And then create the right context or the right circumstances so that you can succeed on a day-to-day basis. And just listed a few here to make the tools that you need access to readily available. A lot of this is about forming the right habits. So develop a routine for your treatments and set the reminders using either whatever you use. Some people use various apps. Engage others to help you and to remind you and keep you on track, and then reward yourself when you're able to follow through and celebrate the successes. This is back to that 2-hour treatment burden a day. That's every day, 7 days a week, every month. There's no break. You have to build in some celebration, some reward. Recognize that you will need help at some point, and figure out when you need to ask for help and who to ask. And then I think relevant to one of the comments earlier is be honest with yourself and within your circle of family and friends, and be honest with your care team. They really can't help you if you don't share honestly what the issues are. And they do want to help. Okay, so let's change the focus a bit here now from your own care or your own child's care to partnering with your do you refer to them as care center or a clinic? Clinic. So partner with your clinic to improve care at your clinic. So let's talk a little bit about that. I know there are resources on CF Australia and CF New Zealand, and you can find things there. I'm just not as familiar with what they have available. So I point you to what's available on our website at cff.org. And it goes through ways that you can improve care, and I encourage you to take a look. And also shown there are what we refer to as success stories. It's back to that, what we've learned is sort of peer-to-peer knowledge transfer or peer-to-peer mentoring is very powerful. Physicians like to talk to physicians. Nurses like to talk to nurses. Respiratory therapists like because they share a culture, they share a background. Parents can talk to parents. And so these success stories are I think, can be helpful. And I'm just going to share one. And I apologize. I know you may not be able to read this from the back of the room, and I'm going to go through and read one of these success stories. And it's from a parent of a teenager, and it's about starting a patient-family advisory council. It all started with a letter I received inviting me to join them in forming a patient-family advisory council. The letter asked me to attend the first meeting with no obligation, just to see what it was all about. The first meeting, what stood out most was the fact that we were simply a group of people all working towards a common goal. Doctors, nurses, nutritionists, foundation directors, social workers, people with CF, and parents. Many meetings have passed since then. Today, everyone on the PFAC is on a first-name basis, and all of our ideas, concerns, and actions are considered equally important. We work hard not to bring our own personal agendas to the table, although sometimes we use personal experience as a reference point for certain topics. I feel that the PFAC is the most natural progression for me as the mother of a child, now a young adult, with CF. Being on the board lets me stay in touch with the providers that have become such a part of our lives. It lets me give back in some small way what they have given to my family. I also take great satisfaction in knowing I'm part of a group that affects change and works to continually improve the lives of so many people. I've also come to clearly understand that my role in my daughter's care is as advisor and supporter, and my role in the CF community is team member, helping to provide the best possible care. So that earlier comment, she was in that sort of tricky time point where she was sort of handing off authority to her daughter when she was asked to join the Patient Family Advisory Council. So there are other stories like this on the website that I encourage you, when you get a chance, just take a look and read those. I think they can be helpful. So, and again, I know you can't read this. I'm gonna go through this slide. The other way that you could help your care center is if they ask you to fill out a survey about what they're doing, the experience of care, sometimes referred to as a patient satisfaction tool or survey, please take the time to do it. These can be enormously informative, and this is something we've been actually working on in the States for several years in collaboration with colleagues up at Dartmouth, and now we're deploying this survey, and I'm very hopeful that this is going to help us improve care across the states, and I'll show you why. This survey, let me back up for a minute. I think I've got something out of order here. Okay. A slide that I forgot to drop in here was a slide that showed all the elements of this survey, or the domains of this survey. There's one related to access. When you call, can you get a response? When you need an appointment, can you get an appointment in a timely way? So there's access. There's one on the healthcare team. Were they knowledgeable and up to date? Did they treat you respectfully? There's one about the hospital. And so there's 4 or 5 different domains. And I'm just going to show you one or two of these domains and why I think this is going to be very valuable to us, and encourage you to follow through on surveys if you're offered to take one. So this one is titled, if you can read it there from the back of the room, experiences with timely CF care. And this is one. This is a domain we call access. So the first question, and this shows the result actually from one care center in the U.S. How often did you get a response to question number one? How often did you get a response from the healthcare team, doctor, nurse, or other CF care team member the same day when you called during office hours? And they could answer never, almost never, sometimes, usually, almost always, and always. In this program, their patients, 63% of the time, said always. And we surveyed about 25 centers in this tranche, and the average there percent always across the board of those 25 centers was 49%. Now look down to the middle question where you see that little green dot. Can anybody see that in the back of the room? Okay, so this question, and I'll explain what that green dot means. When you called the CF Center to get an appointment for care for your child, for care your child needed right away, how often did you get care as soon as you thought your child needed it? This center, the response was 100% always. All those 25%, those 25 care centers or clinics, percent always was 70%. And that green dot means that 100% was statistically significantly different than the average. And I'm not going to get into the statistics. I don't completely understand them myself, but we have a biostatistician that goes through the data. That 100% is a meaningful result. It's just not just a normal variation. And then the other questions I won't go through in detail, but I want to show you. So this is what the biostatisticians use. It's something called a funnel plot. And each of those dots represents one of the care centers. And on the horizontal axis, the x-axis, is the number of patients that responded to the survey. And then on the y-axis is the percent always that was answered to that particular question. And those other little lines, those funnel lines, if there's a dotted line, if a center is above that upper dotted line, there's just a 1 in 20 chance that that's random variation. If they're above that top line, that solid line, it's a 1 in 100 chance that that's random variation. So applying this statistic, we can start to get at, using this survey, who really is better than average and who's really worse. So it's sort of getting at this question. And I don't, we don't want to use this in a punitive fashion. We want to reflect this back to our care centers and encourage them to improve. So again, I know you can't read this, but I'm just trying to give you a glimpse of how we're envisioning using this. So this is just all the access-related questions and using those dotted and solid lines. So anybody that was above that solid line is the darker green. The light green, they were above that next line. If they're red, they were below that solid line. So that's on the worse side. Dark green is on the better side. You can start to see a pattern here, and we can pick up 2 or 3 centers that I think there's an issue there with access at these centers. Whereas if you look down there towards the end, towards the bottom, there's some centers that are just doing a great job here. So we think this is going to, we believe this is going to complement the medical outcomes, which we capture through our patient registry, and we already reflect back to our care centers. We encourage them to work on those health outcomes. We believe these service-related outcomes can also be helpful. So one other aspect of this survey that I think is going to prove to be very valuable, and we're still relatively early in deploying this, but I really think this is going to help us. There are a couple text entry questions, and there are 5 of them. I'm only going to show you a couple examples from 2 of them. What do you like best about the clinic? And they can actually type in or write in what they think. And this is very powerful feedback for those centers down there at the bottom with the green. To get this positive feedback is really helpful. So these were just some things that people typed in. The whole staff go above and beyond to care for my child and have a very important personal relationship with her. They are caring, informative, and great with children. I would highly recommend to anyone. They are very personal and know their patients. They respect family opinions. Okay, probably a more important question. Do you have suggestions for the CF Center to improve care and services? These are actual comments that came in, and we've gotten a ton of these. I can't believe that people take the time to put these in. But here's a flavor for what's coming in. Someone trained in mental health that could help with the stressful mental aspects of CF. Great comment. Offer more teaching and firm protocols for that inpatient nursing and ancillary staff. There's a little bit of a bite in that comment, right? And I don't know about here in Australia or New Zealand, but what we find in the hospital setting, our clinics, they don't have as much control over what's going on there. And in this survey, we see that reflected in the rating of hospital care. To increase communication with families by email, and I would like to get more timely information on lab results. These are all great comments. So I know that one of the centers in Christchurch, I think it's the adult program, has actually piloted this survey. I saw an abstract that they submitted to the meeting, so I'm eager to hear their experience. So if you get asked to fill out a survey, please fill it out. And we do this anonymously, by the way. And I think if you're asked, I mean, if you want to put your name there, fine. But you should be able to speak freely. And back to that comment, you don't want any repercussions. If you're worried about that, do it anonymously. The other thing, and I've already alluded to this from that success story that I related, we've pushed hard for patient-family advisory councils in the U.S. as part of our quality improvement work. And this is just some data that we collect from care centers about the way they engage people with CF and families with CF. And the yellow bars are from 2006, and the blue bars from 2011. And what you can see, so this represents about 250 programs in the U.S., so pediatric programs, adult programs, and affiliate programs. So I think my battery is losing juice here. You can see that the number of programs where they respond to that question, well, we don't have patients and families involved, has dropped off to less than 20%. And what we've really pushed here is this advisory council idea. And you can see that we've had pretty widespread adoption of this, and some of the centers have found this very helpful. And I'm not going to go through these next two slides in detail, just to say that I've been absolutely blown away by what some of these advisory councils have accomplished in partnership with their care centers. And this just lists some of the educational tools that they've developed, and one that I really liked here was this recipe book. They put support mechanisms in place. And they've also, on this next slide, worked in partnership on improving care delivery. And this is the longest list, and I don't have time to go through this. But the clinicians, the care team, engaged them, and parents, adults with CF, stepped up and really invested a lot of time, energy, and their own wisdom. Some of these folks had IT background or business background. They obviously could contribute enormously. The other way that we've encouraged care centers to engage patients and families is to actually bring them on to quality improvement teams. And Cincinnati Children's in the States has really been a leader on this front. And this is their pictures of their quality improvement teams, and there's several parents here. That's in the pink sweater is Honor Page, adult of a parent of a teen. Jim, Tracy, blocking on her name. But these are parents side by side with the clinicians. contributing their ideas to how do we tackle this particular problem that we're trying to improve. So I've been through working at your own personal family level and then at your clinic level. And at the country level, I don't know the specifics for New Zealand and Australia, but I can assure you that David and Kate and others would love your help, because the patient voice is very powerful. And these organizations, they get tired of hearing from clinicians. For example, the institution, the university hospital. The administrators have a long line of clinicians in there whining about one thing or another. We need this, we need that. Their senses are dulled to that. But if there's a parent with them that can say, absolutely, the clinic needs that, that can be very, very powerful. And this is at institutional level, regional level, national level, and we've tried to do this at every level in the states. Our national office is based in the Washington D.C. area, and we have a very small public policy advocacy group, and they've developed relationships down there at Capitol Hill. And then if they need somebody else from the foundation, we go down there. And mainly it's to try to inform them about what CF is all about, what our care model is all about, what our registry is all about, because in many ways we're a model for chronic care, as you are here in New Zealand and Australia. So when you go throughout the day, I want you to try to keep some of these messages that we've talked about this morning in mind. Improving CF care, what you can do. So it's become an e-patient. Think about some other E's that you can add on there. I've just listed 4. You could fill the whole slide, but engaged, educated, empowered, enabled. Again, I know I'm preaching to the choir, or you wouldn't be here. Figure out how you can partner with your clinic on things that are really bugging you. They probably have an agenda as well, and if you can start that conversation, help them on the problem they're trying to solve, and then maybe they'll help you on the problem you want to solve. It's a partnership. It's a give and take. And by this I mean outside of your clinic appointment. This is you don't want to get caught up in your personal circumstances here. Of course, as was pointed out earlier, reflect on your personal experience, but try to operate at that next level. Help them try to accomplish what they're trying to do, and that's improve their service and quality of care for you. Speak up, speak out. You were brave enough to raise your hand, so I know you can do that. Work with your partners, CF Association of New Zealand, CF Australia. They're working for you. I think I'm out of juice here. Oh, I think this is right near the end. The thing that I wanted to point out in this slide is that this whole idea of patient engagement has really caught the attention now of policymakers, and that's sort of in some ways being forced on those skeptical clinicians, because there's evidence that this can improve quality of care. It can help reduce costs. So there was this whole issue of this policy journal, Health Affairs, that was dedicated to this issue of patient engagement. One of the editorials had this quote, "Patient engagement, blockbuster drug of the century." So a number of links here. You've probably come across some of these. Obviously, CF Australia, CF New Zealand websites I've listed there, cff.org. There are others devoted to improvement. I've listed ePatient Dave. You can easily find him from a Google search. So really, this is about really the theme of this conference, right? Getting better together. It's that partnership within your own sort of little family and friend support group, but the partnership also with your clinicians at the clinic, with your associations who are there to support and work for you. And we just refer to it as Team CF, and really Team CF is a global community now. I mean, we meet intermittently throughout the year. We discuss issues. CF in Australia is the same as CF in Washington, D.C. It's the same in Auckland. It's the same disease. Access to the treatments may vary some. Payment model may vary some. But the biology, the disease, and the impact that it has on those individuals and families is really the same. So it's really sort of a global team. So thank you for your attention, and I don't know, Kate, if we have time for any questions.
We've got plenty of time for questions, if anybody has got any.
Thank you for your attention, by the way, and for those brave enough to raise your hand.
Well, Bruce, I'll start off, as any good chair should. I don't know about Australia and whether Aussie's got any of these we call them a patient and family advisory group here, which is the same as your council. So we, in the last couple of years, have run a pilot for a patient, a family advisory group at Starship Hospital, and also an adult group in Christchurch. I guess there is definitely an appetite for those groups amongst our parents in particular. Mostly our issues are around numbers and critical mass, and Aussie would be the same except for the really large centres. You're dealing with centres that have only got a really small pool of families, so unless every single family in that area takes part, you're only going to have a very small group. So I wonder whether there's whether we can also think in these smaller areas of doing things a little bit differently and having collectives and maybe doing Skype cluster meetings and getting the health professionals at a number of hospitals involved to kind of do stuff collectively.
I think it's a good question, Kate, but I wouldn't abandon the idea of keeping them sort of tightly focused around the clinic, because the issues vary from one clinic to another. The experience of that clinic team may vary. The leadership and the teamwork may vary. The access issues may vary. Maybe not because of the team, but it might be the institution there. So these are really sort of local issues, and a more regional approach could be helpful for sharing knowledge and support. But for improvement at a particular clinic, I think you have to get down to that smallest unit. And you don't need a large group. I mean, it could be at a center of, or a clinic of, say there's a clinic of 40 people.
That would be one of our largest clinics, Bruce.
Okay, all right. Okay, gotcha. Okay, say a clinic of 15 people. Clinic of 15 people, maybe you only need one or two. Because what we're trying to accomplish with these is to open the clinic staff's mind. Because what happens, like anything, you get blinders on and you just don't see the issue. You don't see the problem. And so just to hear that perspective and again, it's back to this intimidation factor. Sometimes that's difficult to volunteer in the context of what's happening to your loved one. But if there's a safer venue that is focused on trying to improve, and again, it's not trying to improve Dr. Smith. This is getting off of the issue we're blaming Dr. Smith or Nurse Jane. This is the flow of patients through the clinic, the return call. So this is about working on processes and trying to improve processes to just improve efficiency, improve quality of care, et cetera. And you don't want to get into a confrontational sort of thing. So you don't want this butting of heads. You want to get people on the same side of the table looking at the same problem and then looking up for a vision of where you could take that problem to solutions. So I'm not sure if that's exactly what you were looking for, but I think it's got to be, sometimes people refer to it as the least replicable unit. That's the key unit, that clinic unit.
So I guess if any of you, I won't speak out of school for Aussie, but certainly in New Zealand, any of you here who are in an area and you don't have one of these councils yet and you come away from this conference feeling fired up to form one, talk to National and we will help you do that.
Just answered my question.
And I'm sure Aussie would feel the same.
By the way, while you're moving to this question, I'll just say that some of our care centers have had difficulty getting these things established or sustaining them as well. And some of them maybe were too democratic in their approach. They felt like they had to invite everybody and then, we need one like this and one like that and one like that. I don't think it has to be that logical or organized. You need somebody that's willing to raise their hand and say, I'll be on the call or I'll be there. And people worry about, well, is it representative or what? It's better just to get started. And then once you have a little momentum, then you can sort of worry about those ancillary issues.
Now you've collected the data from the different centres, what's the next steps? Is it incumbent on individual centres to look at the results and say, okay, we need to improve here and here and therefore, or is there some sort of overview and maybe benchmarking the University of Miami, for instance?
Yeah,
which is obviously a very high-performing centre, and then filtering down those kinds of...
It's a great question, and we're trying to figure it out, which way to take this. We're just starting to get the data in enough quantity that we can actually start to do the statistics and figure out the path forward. We do this, by the way, for the medical outcomes already from the registry data. We think this is going to complement that. So right now, the way we're using this is we're using it as part of our accreditation process. So the centers that are due for an accreditation site visit, we engage them to deploy this survey to their patients and families. And we collect that information, and then the site visitors, they go in and they look what's happening there. They spend a day there. They look at their health outcomes. They look at the results of the survey, and then we comment back a critique to try to make it clear to them this is where you could improve. That's just a starting point, though. I mean, what we want to do really is, as you've seen for access, first of all, we want to boost the response rates. We're getting response rates of only about 30%, which is really disappointing. I really thought that we would do much better. And so when you get smaller centers, the numbers are so small, we'll never get statistical significance. So first, we want to boost the return rate on the survey, and then we want to break it down in these various domains. We want to send reports back. Well, we're sending reports back now. We send a complete report back to each care center showing their results and the average results with the green dots and the red dots. This analysis that I showed you, that summary, is the first time we've had a look at that. We only have it in that one domain. But the idea would be to really generate those in each of those 4 or 5 different domains and start to do some benchmarking. What is it that you do at South Dakota that's not happening in Las Vegas? And try to start to connect those centers. We can point them to some resources so that they can improve in this area, or we can start to try to connect, pair up care centers, again, back to this idea of peer-to-peer mentoring. In our quality improvement work, we've really found that to be the most powerful way, that rather than me lecturing them, another physician director talk to their peer, or a nurse talk to a nurse peer. But if that care center, if we say, for example, Las Vegas, if across the board they were delivering poorly on service-related outcomes, perhaps we would suggest to them that they go visit South Dakota and spend a day there and see the way their clinic operates, because that stimulates ideas. So I don't know if I completely, but we're just scratching the surface on this at this point. So we hope to really sort of leverage it and gain a lot of improvement from it.
A good presentation. Engaged, educated, empowered, enabled absolutely rings true. And, when somebody starts out on the journey of cystic fibrosis, the parents obviously are a big part of this care partnership that you talked about. However, it was touched on early in the presentation, and the comment from my lady over to my left, that of course as time goes by, our job is to get the child to be much more independent, and so the parents' ability to be engaged and empowered and enabled, of course, if everything progresses well, becomes less and less. Now that's a big problem and a big dilemma. I mean, in normal life, outside of cystic fibrosis, we allow our kids to make mistakes and they learn through their mistakes, etc. However, with CF sharpens the consequences of those mistakes, because inevitably they lead to reduced lung function. So a lot of parents feel a lot of anguish, out of love. They don't allow their kids to make those mistakes, and I think this is a very difficult area. Well
stated. I don't really have anything to add. I think this is a really important time in life, and this whole transition is critical. It's critical, and it's not a light switch. It's I think it probably plays out. I was going to say a decade, but probably more than that. I know the male brain doesn't mature as well. Probably a 30-year-old male brain is not fully mature. May still need, maybe my wife says a 50-year-old brain. But anyway, your point is well taken. I think we probably in healthcare need to be a little more intentional about this. I think we've tried to be, and there have been transitional programs that are aimed at really supporting what you're talking about, trying to start to transition from parent to child as a young teenager and monitor that progress. And then there's a transition in healthcare that happens as well to an adult care model. It's a really dangerous point in life, and it has to be handled well. And again, I think it plays out over a long point. The other point you made, I think, is again well taken. That the consequences can be big, and you don't want somebody to learn from their mistakes here. And I've seen that. I've seen that personally. What's your thoughts? What? You're very articulate. Do you have what's your thought on a best solution for this?
Sorry, I'm trying to do two jobs at once here.
Look, I don't have an answer, and my context is I have a 15-year-old girl with CF, and so we're going through this very much at the moment. Look, it's got to be a partnership. Obviously, as parents, you've got to give children that freedom. Otherwise, they'll never get to a point of independence, and clearly, you don't want to be there. And unfortunately, the levers you've got to influence them as they grow older become less and less, or they become more subtle. And every situation is different. Every individual is different. Their family situation is different. We're quite lucky. We're two parents with a child. There are single families, single parent families, different pressures. So I don't know that there is. It is a very difficult area, I think I'm just echoing what I've heard from other families as well. And I don't want to belittle the message that you've given, because I think what you've said is very true. Engagement, education, empowerment, enablement, etc. And that's it's a good system, yeah. But when the rubber hits the road with that system, there are many more complexities that sort of mitigate that, yeah.
Absolutely. What I've laid out is just basically a framework or a model. And I don't know, somebody made that comment. All models are flawed. Some are useful. Maybe this is useful. I think you're absolutely right. It's all about that individual's context. So I think you're right on with your comments, and I think your earlier comment I think is also right on, that you're moving from an authority figure to an influencer, and perhaps using other people to sort of strengthen that influence, like the clinic staff, like a sibling, like a friend, the friend network, that sort of a things. As you step back, you're perhaps starting to put that safety net, so to speak, in place. Again, I think I'm grossly oversimplifying, but anyway, great comment. Thank you.
Yes, I just wanted to add one thing to that discussion. I'm from Otago in New Zealand, and I feel very fortunate that we have a clinician there that looks at the sort of the holistic approach and recognises these things early on. As I say, my daughter's 11, coming up 12, and what we've done there is introduce the psychologist into the team, so that, but it's still, the onus is on parents to red flag these issues, because some of us, single parents especially, have trouble letting go, and because we've had to do everything. We haven't necessarily had a partnership in the care that takes place at home. So I know when I was working with a partner, there were things that I could relax on because I knew he would pick it up. Being a single parent, we've got to be hyper-vigilant, if you like. So it goes against the grain to release the power and actually actively disempower yourself in order to empower your child, because my child's a girl, I'm a woman, so you've got another dynamic there that, and it gets worse because I've got older children, and yeah. What I'm saying is that it's something that it's beneficial if we highlight this early on with our clinicians, and hopefully there's some input that can come in where the child has that place that they can go, and they can go, my mum's and really vent and get some of, so you're not getting so much at home. And I've found that very useful.
Thanks for your comment.
We've got time for one more. I will draw your attention to the fact that we do have a speakers corner outside, which our lovely speakers throughout the day will be going to for 10 to 15 minutes after their talk if you've got something burning and you missed out on the question section.
Hello everybody, my name's Kylie. We have an 8-year-old boy, he turned 8 yesterday. We're from Queensland, so hello from sunny Queensland. I'd just like to make a comment that right from the time that Lockie was able to speak, that we encouraged him to actually speak with his physician. So whenever we go to clinic appointments, we actually push him forward and discuss with him what it is that he would like to discuss with his doctor. He's drawn pictures of things that were important to him at the time. And quite honestly, some of the questions that he has or the comments that he has for his specialists are quite frightening and things that we wouldn't necessarily have brought up or discussed or thought to discuss with him, but they're things that he may have heard in passing or other people actually speak about and wanted to get more information about. But we also have a very good specialist team who actually actively seek out his information and ask him the question, how are you feeling? And what does that feel like? And are very good at obtaining that information from children, I suppose, which is a different element. And I will never forget one of the first times he was saying that he had a pain in the tummy and he was using hand signals to explain it, which I'll have to stand up to do. I'm a teacher, so sorry, I feel very comfortable speaking in front of people. But he was talking about a pain in the tummy that he had and he said, it's like this. And the doctor said, oh, I know exactly what that means. It's more of a cramping, more of a colicky pain. And she said, so it feels really tight and then it kind of gets a little bit easier and then it feels tight again. He goes, yeah, that's exactly right. And I mean, to have the words to explain to us, we would have had no idea what he was talking about. But the fact that he now feels very comfortable talking to them and having that relationship with them is very important, especially as he moves into his early teens and then into adulthood. So that was just an example of how we've been able to hopefully help him develop that relationship very, very early on.
Great, thank you.
Hold this down here so I don't get any fold back. Thank you so much, Bruce. That was fantastic. And thank you to everybody who participated. I think, gosh, we've got some really good speakers amongst our audience. I think we should be taking names. You know, what I get from that is, number one, you guys are the experts, but you've got to be prepared to speak up and you've got to be prepared to question and to talk to your team. The other thing that I think it's important, I think often when we're being provided a service by someone, our tendency is to only tell them if things are going wrong. All of the people who serve you in your clinics and centres are people, and they're people with a great passion for CF. So remember to tell them when things are going right as well and when they've done a good job, because life is all about relationships. It doesn't matter what you're doing, it's all about good relationships, and that's exactly what this talk was all about.